Okay, everyone, thanks for bearing with us. We're just about ready to go. In fact, we'll start now. So over to Danny.
Okay, thanks, Mirek, and welcome everybody to this National Clinical Audit Patient Outcomes Programme seminar. This is a very ambitious seminar we're running, so bear with us because we've got a lot of themes that we want to push in, but there is one main theme that we really want to get going on, and that is on the title, how are the national audits stimulating healthcare providers to improve patient outcomes? That last bit's really important. All the work that we're all doing, how we're making sure that it is improving patients' outcomes, and that's what it's all about today. And if I wasn't close enough, we got an email this morning from NHS England that reinforcing again, they want to be assured that the programme that they're paying for, that it is improving the quality of patients' care, that is what's received care and acted upon. So it's really an important theme, this. And we've got a meeting in two halves. The first half is themes around data and the where we are right now, and then the second half we've got some audit providers who are coming along to talk to us about how they're getting on with this theme of improving patient outcomes coming on from the audit programme. So without going on further, I'm going to introduce, so we won't do introductions all around. I'm Danny Keenan, Medical Director for HQIP. The colleagues who present are going to introduce themselves, but we're going to kick off firstly with Rebecca Randall and Lynn McVeigh from University of Bradford, talking to us about the QualDash project. So Rebecca and Lynn, can you come in and present? And these are very short, succinct presentations. So thanks, over to you.
Okay, so I'm just loading my slides, if you bear with me.
And while you're loading, the title of Insights from Using and Visualizing National Clinical Audit Data.
So thank you. So yes, we undertook a study to design and evaluate a quality dashboard for looking at national clinical audit data. Before I go any further, I'd just like to acknowledge the team that undertook this work with us, and also our funder, the Health Services and Delivery Research Programme of the National Institute for Health Research. So the project aimed to develop and evaluate QualDash, an interactive web-based quality dashboard that supports clinical teams, NHS trust boards and quality and safety subcommittees, with the idea that this would enable them to better understand and make use of NCA data for quality improvement, and that in turn would lead to improved quality of care and clinical outcomes. So we undertook this research with 5 NHS trusts, and we were focusing on 2 audits, MyNAP and PeakNet. So we looked at MyNAP across all 5 trusts, so 3 teaching hospitals and 2 district general hospitals, and then we looked at the use of PeakNet across the 3 teaching hospitals. So to inform the design of the dashboard, the first phase of the study was undertaking interviews with staff across those 5 sites to understand how they use National Clinical Audit data and what gets in the way. And we found that there was variation in the extent to which trusts use the data. So there was lots of motivation for using the data. So for example, clinicians saw it as part of their role in caring for patients. But in sites where there was greater use was in sites where they had particular resources. So specifically where they had their own local database for using the data prior to uploading it to the NCA, and people. So specifically audit support staff who had the skills and the time to be able to create reports and visualizations using that data. It was more constrained in sites where they didn't have their access to their own data in that way, but also it was influenced by perceptions about the likelihood that the necessary resources for quality improvement would be provided by the trust. So I'm now going to hand over to my colleague Lynn.
Thank you, Rebecca. So I'm just going to talk very briefly about things we learned about visualising the data from the co-design process, which we undertook with OneTrust, and also from the evaluation process. So first of all, what the users told us they wanted was at-a-glance visualizations of key metrics such as mortality when they first logged into the dashboard, and they wanted simple visualizations. Obviously, there's some very sophisticated and wonderful visualizations out there, but what they were really interested in was simple things like bar graphs and pie charts. And as Rebecca said, some of the trusts we worked with had existing systems, databases, spreadsheets and so on, that they already used to manipulate National Clinical Audit data, and they wanted the dashboard that we provided to be configurable to look like that, because they knew those ways of presenting the data, it was familiar with them, it didn't take them ages to understand the data. So that configurability was really important, and they wanted it to be familiar. Again, in a similar way, they wanted functionality that supported the current way that they used the data. For example, we worked with audit support staff who every month produced charts to clinical governance meetings in a certain way, and they wanted Qualdash to be able to do that, and they wanted to be able to interrogate the data and drill down to look at specific relationships and groups of patients. So next slide please, Rebecca. I'm just going to finish very briefly by showing you some examples of the Qualdash dashboard. This is a dummy version, it's not using real data, but it's the PICANET, the Paediatric Intensive Care dashboard. So if you don't mind just going back for a second to the previous slide, Rebecca. This is the login screen with the key metrics displayed on separate little squares that we call qual cards in simple bar charts. So for example, there's mortality, 48-hour readmission. If you click on one of those qual cards, and if you'd move now, Rebecca, to the next slide, then you can drill down to look at further information. So you can see, for example, a pie chart that shows you the ethnicity of, if you were to click on one of these columns, you will be able to see the ethnicity or the diagnosis of the people admitted in that month. So I know I'm going towards the end of the time there. It's a bit of a whistle-stop tour, but that's Qualdash, and any questions we'd be very happy to answer.
Sue.
Oh, Danny, you've just muted yourself.
That's frustrating. I'm just clicking on and off. Thanks everybody. Any questions for Rebecca or Lynn on that whistle-stop tour of their dashboard? You've stunned everybody, Rebecca, and then I think they're probably all recovering. Clive, far away. Clive's got a question.
No, I was just going to ask. So, what has happened with it, and presenting this to the clinicians? What has happened as a result?
So we found, so one thing to say is that our evaluation, it was meant to be a 12-month evaluation, but it was cut short because of COVID. what we found, so we'd done kind of user testing before we introduced it into the sites, but using dummy data. Although we'd done it according to what the people who were involved in the code design asked for, issues came up when they started to look at use the dashboard to look at their own data. So I think that was a lesson for us. You know, when you're doing that initial user testing, people do need to see their own data, because otherwise it's, you know, I think there is less concern and it's less easy to identify differences in how you would expect it to be presented. I think the other thing was, again, we saw variation. So those sites that already had access to their own data continued to access the data in the way that they already were. It was quite hard to change those processes, whereas it did provide benefit to those sites that didn't have access. So they were able to identify issues in the quality of their data, which they took actions to address. And it also helped them reduce the time required for reporting, you know, so kind of reports to the centre that they needed to submit.
That's super. Thanks for that. We'll move on. That's great introduction. And we're going to move on to Robbie now. Robbie Foy presentation is recent learning from improving audit impacts based on research. Robbie, do you want to take on now?
Yes, thank you very much. Once upon a time, well, in about 1990, around the time of a forever unpopular purchaser provider split, the BMA produced a protest poster. It said, "What do you call a man who ignores medical advice?" Oh, it's not moving.
No, we can't see anything here, Robbie.
Oh.
Is it the Secretary of State for Health, by any chance?
Oh, someone's always busting the punchline.
Absolutely. We're still laughing though.
Have you got it now?
Yes, we've got it now. Thanks.
Thank you. Okay. So this is, we also have a time of unprecedented unwanted advice, guidance and checklists in the NHS. Some of it comes from well-intentioned researchers like me. So how can I possibly sell you yet another checklist? So first of all, a quick word from our sponsors. Thank you. So here's what we know about audit and feedback. On average, according to the Cochrane review, it's got an effect of 4% on processes of care. However, that modest effect can translate into population healthcare improvements if it's scaled up. And also, if you keep doing it, then you can have cumulative benefits over time. The interquartile range from the Cochrane review was 0 to 16%. So in other words, 1/4 of feedback had no effect and 1/4 had quite a big effect. So with feedback, if you do it wrong, you can make no difference, or even do harm. Do it right, you can make a big difference. So how can we put together some of the findings from various studies that have been going on in the last few years? Well, thinking about trying to make the work useful for you, well, yeah, you know, you come up with the idea of a toolbox and then some way to measure how you're doing compared with what's recommended from the evidence on effective audit. So I'm suggesting a self-assessment report card for audit programs that would act as an aid memoir, allow some quality assurance of audit programs, and perhaps also allow you to strengthen business cases for new or continuing programs. The report card itself covers 5 domains with 19 points. So, for example, here are just 4 of them. So they cover areas such as goal setting, content and delivery. So for example, if you notice the bottom one, it's about trying to minimise cognitive load for feedback recipients, which also came out in the preceding presentation as well. So I guess my question to you is this sort of thing a dead duck, or is it the bee's knees? So I'd really like to know. I think Mirik circulated a copy earlier. Luckily, of course, senior government people ignoring medical advice is a thing of the past. Thank you.
Well, thanks, Robbie, for that. That was very concise. Robbie, would you like to see if we can get some feedback from the distribution of the checklist, as you call it, from colleagues who have had a look at it before we started? Any colleagues?
Danny, that we did circulate this to our providers of NCAPOP. So you may or may not have come across it. This isn't a who hasn't sort of punitive test, but if there is anyone on the call that may have received that email and checked out that self-assessment scale, have you had a look at it? I guess Robbie would be great. Oh yeah, we've got a hand up.
Hi, I'm John Hurst, Senior Clinical Lead for NACAP, COPD and Asthma Audit. We've not actually applied the tool to NACAP, but I really enjoyed reading it. I think it's going to be very useful. Lots of things to think about in there. So I think bee's knees rather than dead duck, but we've still to actually implement it. So, but thanks.
Hi there. I think Jennifer Buck, you were probably next. Do you want to fire away?
Hi, I'm from SNAP, and I read through it, and we actually used some of it for looking at where we could be making improvements to how we do SNAP in the future.
Okay, so that's a positive.
That was very positive. Yeah, we did. We were very pleased to tick off lots of things that we do right. I mean, I do want to say we were doing lots of things right. That's okay, but it helped identify a few other areas where we could be doing them, things better. Excellent.
Jane, Jane, do you want to come in?
Right. So, Robbie, I think we've already been in communication about your paper, and it's around the RCP. And again, I'm glad to hear that John thought it would be very helpful. I just felt it should be clear as to who it was aimed at with the paper that came. It may be not just for a lead. I felt it would be probably better for a governing board to use that as a review within a board rather than just a lead was my feedback, but I thought it was very helpful.
Okay, so that's three positives. Just to be controversial, is anybody who maybe think this is overburdensome or it's giving us too much to do or whatever? Any other thoughts on the checklist? No, everybody's very polite here.
Yeah, I was going to say it's a public forum. You don't need to be polite online. Jane, thank you for your feedback. If you get a chance, please do take a look at it. I'd love to get feedback, and I think we need to clarify that this is a very select and knowledgeable target audience we're aimed at. So in the case of many audits, a lot of you are doing a lot of this stuff already. So this is just to remind you of other areas to look at. Thank you.
Excellent. Clive, join in.
I was just going to say that we can get a bit sticky in the mud with our own audits, and simply to see what we're doing re-articulated in a way that becomes a common currency is not a bad thing. So, I've not seen it, but I'd welcome the opportunity of comparing how you've described what we should be doing against what we feel we're doing. That would be great. Thanks.
Excellent. Thanks, Clive, for that. That's excellent. Thanks, Robbie, for that concise presentation. Excellent. And I guess we'll be wanting to get some more feedback from that afterwards as well. So, Michael, I think you're next. Michael Sykes next, and Michael's going to be talking in relation to diabetes, in relation to insights from 3 studies exploring what happened when the diabetes data reached the hospital. Obviously, very pertinent study, given some of the variation we do see coming in from the inpatient study for diabetes. Are you okay to fire away, Michael?
Thank you very much. And just to clarify, this is going to start off with the earlier work that related to the National Audit dementia before moving into diabetes. Before I do, though, I'd really like to position the work in relation to the kind of the level that we're looking at. So national audits might have an impact on individuals by individual looking at the audit data and changing their own behaviour. It might have an effect at a national level where the national audit stimulates a national improvement action, for example, changing incentives in QOF perhaps. But what we're really talking about here is this kind of local level improvement, organisational level improvement. So what we did, and I'll describe the full team at the end, is to study what happens when the National Dementia reaches 6 hospitals in 4 trusts. We use interviews, observations and documentary analysis, iteratively taking that data back to a co-design group. Briefly, what we found was that the National Dementia arrived back at the hospitals as a 66-page report, and it tended to be read by 2 or 3 people. That would tend to be a clinical lead and perhaps an associate director of nursing. They sometimes found that report quite confusing. And one of the things they did was to identify local priorities. And we were quite surprised that some of the local priorities that they selected were things that their performance was actually quite high. And some of the priorities that they didn't select were things that their performance was quite low. Their task, if you like, was to take that data and translate it into an organisational action plan. That would go to a committee, typically a directorate level committee and 1 or 2 organisational level committees. Observing these committees, the sense-making work that went on both between levels and between hospitals was very similar. So there'd be a discussion as to what do we think of the data? Is it balanced data? What do we think of the source of the data? There'd be consideration as to how does data relate to other data they had, and this was typically complaints that they would go back to as, if you like, their version of truth to try to validate the data. There'd be consideration of where have we failed. This would be where are we in the bottom 5 or 6 nationally, and then how does the data relate to organisational priorities or organisational risks. There'd then be a discussion about what existing work is on the way and what new ideas we have. And the outcome of that would be an organisational action plan. Looking at these action plans, 3 actions appeared very common. One would be change the health record, another would be further audit, and another would be further training. And we couldn't find how they had identified those based upon an analysis as to what's influencing performance at the moment. The outcome of that may then be actions that some of which may reach the patient. So working with the co-design group, we then identified how could we enhance that process. And so we focused in on the action planning process. We looked at what were the capabilities or the behaviours we wanted the recipients, those 2 or 3 people, to undertake. And we wanted them to specify the goal based on their local performance. We wanted them to analyse what's influencing care at the moment and then select actions that are linked to those influences. We wanted them to collaborate with others so they weren't all learning in parallel, to develop local feedback mechanisms to see whether their improvements are making a difference or not, to engage stakeholders. And we thought that would change the information that informed their improvement actions. But it wasn't just that, it was also about identifying how can they generate organisational commitment. So for example, how can they link the national audit data to other existing organisational priorities, and how can they consider that existing work before it gets into the committee room. We then tested that intervention in 2 hospitals, interviewing those people involved, and they described that the intervention was delivered with fidelity, that it was appropriate, but there was something about the time, and exploring that, it didn't necessarily seem to be that they didn't have the time. A lot of people were undertaking this in additional work already. It was more the fact that they wanted recognition for that time, for example, in job plans. We then translated the intervention from the National Audit Dementia to the National Diabetes Audit, and again tested this out in different hospitals, and that's a exploration of that's been undertaken by people not involved in the intervention development. In addition to that, we're translating the intervention from the English National Audit Dementia to the Irish National Audit Dementia, and again, exploring its feasibility there. So I guess my takeaway messages are, be very explicit about what are the quality improvement capabilities we want you to develop. Think about how you want it to development. Is it through face-to-face or virtual? Is it through written materials or some sort of electronic toolbox? And is it just capabilities, or is it also something about motivating people to undertake this work and generating the opportunity for them to do so? So finally, the next steps are to look at, does this make a difference by comparing the quality improvement intervention against no quality improvement intervention? And then subsequently, does the current version do better than a later version? As with others, I'd like to thank the various people that have been involved and welcome any questions that you may have.
Thanks for that, Michael. That's very thought-provoking, actually, because it really does tackle how you really make a difference with these outputs from the audits. Any questions that anybody wants to put some points to Michael? Anything coming forward? Maybe I could ask a question, because this really gets to the heart of it, doesn't it? You know, my heart kind of sinks a bit when you hear that the audits is coming in to a committee for the committee to look over it and think about it. But I can see how you've got a more structured way of doing this, and I guess that bit of where the output from the audit is sinking in with what the trust is wanting to do makes it very powerful. But have you any thoughts about when it's not exactly the trust priority that we do such and such and such somewhat differently? Any thoughts on that, Michael?
I suppose what we did find was that the kind of organisational reach for the national audit data was really strong. So committees and senior positional leaders were interested in the data, and perhaps contrast that with some of the other audits that I've studied. So it would be quite unusual for them to not be interested. Sometimes there was work needed to do to translate the findings, or to say why this is important in terms of things that were priorities. So for example, to link that some of the diabetes work against an existing organisational priority around obesity, or to tie it in with existing work streams, for example, around digitisation. So there's sometimes kind of translation work for them to do.
Thanks for that. James Calvert, James, do you want to come in?
Yeah, I really enjoyed your presentation, Michael, and it very much chimes with less rigorous research done at the British Thoracic Society looking at our national audit programme, and work that's been published by John Hurst, who's on the call, and colleagues at NACAP, where we found that cross-sectional audit on its own doesn't seem to produce change in behaviour. But if you link quality improvement education, NHS incentive payments, and access to data presented in a way that facilitates quality improvement, you actually see quite significant and rapid change. And if I look at what motivates clinicians, it's generally sort of patient-focused and quality-focused. And organisations are also motivated by that, but they're also driven by carrots and sticks. The carrots being financial incentives or enhanced payment, I think, and the stick being regulatory sanctions to fail to meet certain targets. So I think you need motivated clinicians and organisations that are focused on the correct things to get that alignment, because you need organisations to free up resource and time to enable clinicians to facilitate change. I think.
Just add something to that, James, if that's all right. So I guess what you're saying resonates with what we found in that at the directorate level, the conversations were often about patient outcomes. By the organisation level, it tended to be reputational and financial risks. So I suppose what we were asking the clinicians to do was sometimes translate the audit data in terms of this is what it means in terms of financial risks or reputational risks. So it was speaking the same language as the people around the organisational table.
Yeah, thanks. Chloe, you'd like to come in? Far away.
Oh yes, thanks. I just wanted to say how much I agree with Michael that there's the very important sort of interface step in getting people to think about why these are priorities, because when they get their report, you don't want them to be thinking, well, our priority now is to complete our action plan, because then you do get something which can be quite vague. So, for example, in a national audit dementia report, they might discover that they were quite low on delirium screening, and then have something like, we must talk to the junior doctors about doing this better, but it doesn't actually get to the source of the problem. And I think that that's why our audit and many other audits now take further steps at local reporting stage to talk to people about how they begin to diagnose what the actual problem is locally, in order that they can undertake effective quality improvement. So, I mean, in sort of a workshop with people, so they might start out by saying, the problem is that junior doctors don't take this seriously, which is not actually going to get you anywhere. And you know, then sort of get talked through the quality improvement steps of diagnosing why that isn't a priority for the members of staff who are supposed to be undertaking the particular screen, and see what the barriers actually are before you can actually focus on the quality improvement.
Yeah, I agree with that. Michael, do you want to come in on that?
Yeah, I suppose always delighted that you agree with it, Chloe, given that this is one of the audits that you're involved with. But I think that we do need to recognise that work to understand what is influencing performance at the moment is really difficult work. It's time consuming and technical. And so we need to think about how we do support people to carry out something that some of the clinical leads that I interviewed said they don't do this work for anything else. It's just the national audit that they do this work for. So they need some support to do that work.
I mean, I think that there's also, you know, that what really chimed in the earlier presentation was the about resources. If people aren't supported to do the audit and quality improvement work locally, then it can be just one person who's supposed to be the lead for that area all by themselves. And that's not how you can get quality improvement work done. Yeah,
that's absolutely true. One of the things I found with the diabetes audit was linking it with safety in the hospitals, you know, the hypos and hypers. When we presented that work around our various hospitals, that certainly brought everybody's attention to focus pretty rapidly, actually. James, did you want to come in, James Calvert?
Sorry, old hand.
Okay, sorry. Any other comments on Michael's presentation? Any other thoughts? No, that's great. Thanks very much, Michael. So we're going to move on to the fourth talk, which is given by Ian. Ian's our own fellow in HQIP, and Ian's going to tell us about some of the work he's been doing on a fellowship from the Health Foundation. Ian, do you want to take over?
Yeah, thanks, Danny. So hopefully the slides are going to share any minute now.
Yes, this is the moment of truth always, isn't it?
Yeah, yes.
Brilliant, thank you. So I've just got 7 slides. I'm going to just present some reflections on this fellowship that was funded by the Health Foundation for 2 years, and I've spent the last 10 months working with HQIP colleagues to implement some of the recommendations. So the first reflection from the programme of work was there is a pretty wide range of capability, capacity and enthusiasm to use NCAPOP to stimulate QI, and by they using it, I'm referring to audit providers as they stand. So what we did to assess this more formally was create a scoring system with 3 domains around QI, readiness, provider support and national levers. So for example, on the QI readiness, you scored more highly if you were an audit that presented your results back as run charts, and obviously less highly if you only presented your audit findings as an annual PDF. Similarly, for the support for local QI, you got a higher score if you were an audit provider that put on improvement collaboratives, whereas a lower score if you had nothing or just some online resources that were passive. And then the final one was the national levers, and that was linked to what's been mentioned already, the importance of financial incentives. So if you've got BPT or Sequin linked to your audit, you get a higher score. So you can see these are all the audit providers currently commissioned via NCAPOP, and there's quite a wide variation in scores across the programme and by domain. To try and address this, we introduced a template to promote a quality improvement plan or strategy for all the audit providers to really try and standardise this and try and get it nailed down. So that was fairly successful in terms of implementing this and getting QI plans back. And what we did was we repeated the scoring system to assess the capacity to stimulate QI after the plans were introduced and implemented. And on the whole, we saw some improvement in scores. So you can see the blue bars are those at the beginning of the project, and the orange bars are those at the end of the project. Predominantly, the improvement in scores were those audit providers that started off with a lower score. Still quite significant variation, though, in terms of the overall scores. As part of the QI plan, we were really keen that audit providers were much more specific about what they were trying to achieve with the audit program. So what did success look like? So we wanted 3 to 5 QI goals in there with fairly specific, measurable targets in there. So in terms of what we got back, well, we got 22 plans with goals, and there were an average of 3 goals per plan. I think audit providers did struggle to make these quite specific, so it was hard to know whether or not these goals had been achieved. So we could only do that with 33 of the goals. But where it was possible to do so, two-thirds had achieved those goals. So that was quite helpful in terms of measuring success. And then the final strand of the work was around the people for whom these results and programs are intended. So that was predominantly audit professionals within trust, but also clinical teams working with the NQICAN group, which represent this group. So the overall feedback that the National Clinical Audit Programme is respected and appreciated, but is seen as overly burdensome in some respects, in that the data sets are large, the number of metrics is high, and there's a lot of focus around the mechanics of collecting and submitting the data, which doesn't leave a lot of time or resource to then use the data for improvement. So that kind of mirrors some of what we've heard from the other talks already.
1 minute to go.
So the opportunities we've identified and are implementing at present is that all new audit specifications will include a requirement for specific improvement goals. The datasets performance metrics are going to be streamlined, so generally a maximum of 10. There will be a move to more regular feedback and reporting of data, initially quarterly and then monthly. The annual report's going to be dramatically reduced, and there's going to be plans to work with the National Improvement Departments and initiatives much more closely. And it's good to see NHS E&I have just set up a task and finish group on which I'm sitting to try and support some of this work, which will allow the audits to kind of come together with all these other programs. And that's the QI scoring system. If anyone needs it, we can share the slides after. So I'll stop there, Danny, and happy to take any questions.
Thanks very much, Ian. That's great. I love this work. So this paper from Ian is now open to colleagues to knock about and ask some questions. Any first questions? Well, if that's the case, I'll ask a question of you, Ian. So, how receptive do you think that the average audit provider is going to be to this, given that I guess we've all been doing what we've always been doing, you know, and suddenly dropping down to 10 metrics from 30 metrics, and from the lovely annual report that I love to write, down to 10 pages, kind of with concise thoughts and actions and things. So how do you think that's going to be received?
Yeah, I think it will be received variably across the programme, Danny. I think there are some audit providers that are fairly tied into the long annual report and annual publication of data. But there are those, particularly perhaps the more recent ones, that have really embraced a more modern way of working and trying to drive improvement. So I think we have to hold those up as the kind of examples of really good practice and try and just support to bring everyone with us on this journey. But it will take some time to transition, and particularly the aspiration to get the more timely feedback of data. But of course, if you report less and measure less, it's going to be easier to feed it back in a more timely fashion. So there's lots of advantages to being a more streamlined program, aren't there?
Thanks. And just to put a caveat in, that we are working with NHS Digital to get round the delays, the inherent delays in HES and all the rest in ONS. So in some respects, if we could park that one to the side, because that's something that's really important that we are separately working on. Robbie, hi, join in here.
Just a quick shout, Ian. I really liked that. I'm aware that we are our presentations have covered overlapping territory. So just a quick note to say that if you want to make sure that we sing from the same hymn sheet and don't accidentally give opposing messages, it would be good to catch up afterwards, unless, of course, there's a much increased demand after this meeting for more checklists and toolkits.
Okay, thanks.
That's great. Thanks, Robbie. And just to say, Robbie, there is a report available for my work, which you can access via the HQIP website. Yeah.
So could we hear from an audit provider? Just say, because this is relatively radical, and this is coming into new tenders and in particular retenders, which obviously we're doing quite a lot of retendering at the minute. So, you know, if you might come along with your 30 metrics and suddenly being asked to produce 10, yeah, anybody want to give us any first thoughts on this? Are all of our audit providers shocked? Sorry, Sam, I see your name's gone up first. Sam, far away.
Hi, I was just going to say that it is a good idea. I think there will be considerations needed in terms of the volumes that you would expect to appear, because if you're looking at monthly results being published and the volumes aren't sufficient to do that, you're probably going to get everything masked and it doesn't show anything. My second question is, does this monthly publication need to go through the NHS England SRP process that takes 3 months? Or is it going to just be instantaneous? Because obviously if there's a massive lag in when the data is being published, it may have less of an impact.
That's a good question. Ian, do you want to take on that?
Yeah, so no is the answer to the second part of that question, Sam. It'll be very similar. I don't know if any of you have seen the hip fracture audit and their online run charts, which are publicly available and don't go through that process. And one way around the small numbers and other audits do this is to just do a cumulative update. So you might do 12 months and update it every month, and that gets around the small numbers issue.
Thanks, Ian. Sam, or do you think, Sam, are you next?
Yeah, thanks. Hard to get two Sams just sequentially to say something similar. I also think it's hard for to ask people who are currently tendering for an audit to be critical of the tender process. So that wasn't really asking a reasonable question, Danny. But I think there are actually real issues about. It depends a little bit what HQIP actually mean by reducing the number of measures or metrics, and because I think this I'm struck by how diverse the audits are. You know, from very large number of measures to very small number of measures doesn't necessarily mean that one's got too few, or by contrast, one necessarily got too many. But there is just something about making sure that the data flows don't fall over so that one can switch measures around. So I think I actually generally think that the challenges we've experienced with our new tender, that they're quite welcome. In some ways have made us think differently, and it's a good thing. But I worry slightly about the potential inflexibility of that model. So I think it's been interesting and good. The small number stuff I think is a real problem actually, and more of a problem than you're suggesting for some audits. And I think monthly data feedback might not actually be what people want, but we want to ask the audit users what they want, and that's our intended response to that.
Just before you leave that, Sam, what about the annual report? Because that is a bone of contention, the big annual report, and slimming that all down.
I don't think that's a bone of contention at all. I think that's one of the challenges that I kind of quite. I think people are pretty rude about the fact that it takes such a long time to produce an annual report. So that in some ways, I think that's why the real timeness, I guess, is anticipated will leapfrog. The real-time data will leapfrog annual reporting. I think annual reports probably do have in the interpretation in our own audit. The interpretation was going to say since I've been involved, but that's not to say I'm nowhere in any way responsible for the improvements in interpretation that have taken place. But I think interpretation really does add significant value. We have a way of creating key findings and recommendations that is rated as really adding significant value and getting kind of buy-in from national, well, from various organisations, but all of them national. So I think both are valuable. I think the idea of making it short is no problem at all. It's quite challenging. It's not easy, but that doesn't make it bad.
Okay, thanks.
So I'm basically okay with that.
Cheers, James. I think you're next, James.
Yeah, so I completely agree with everything Ian said, and I think it's generally a direction of travel we've been trying to move on in the respiratory audits, and my only concern would be about the 10 data points, because what I would say is that you should collect the smallest amount of data possible and no more. And the HQIP could very correctly provide significant scrutiny to what data is being collected. We now have a small number of clearly articulated national improvement objectives, and we've just gone through an exercise to make sure that we're not collecting any data that doesn't contribute to an understanding of those objectives. I haven't counted up how many there are, but I suspect there may be more than 10. But it's definitely the right thing, and everything we're looking at is real-time data reporting, shorter PDF reports.
Thanks. Jane, you're next. Jane, you.
So thank you. I'll echo James's comments. I think it is really important to check what the users want as well. And I agree with Sam's points about we cannot expect every clinician to know how to interpret the data correctly. And I think it's really important at some stage there is some interpretive analysis that allows people to understand what they're looking at and how they're looking at it and what to do. We're speaking in a forum where we're doing this because we feel really comfortable with it, we understand it, and we know what needs to be done. And I'm not sure that that's in some of the presentations we've already heard. It's apparent that that's not always the case. So they're striking the fine balance between reducing the amount of data that's collected, making sure it's meaningful, but the interpretation and the support that goes to the clinicians that we're aiming it at. And I do wonder if that just needs to be checked out before a really big change is made, because otherwise we're going to be like telling patients what we think they need to do, whereas without checking it with them first. And I just wonder if we just need to check that out. And I'd also, moving towards automated data is important, but as we are finding out, there are lots of hazards along that road, and that it's being really clear about how we get them, how that's supported, and the accuracy of the data we're prepared to accept, put into an audit programme compared to routinely collected and automated data extraction. I know that's probably a topic for another webinar, but it sort of could be a little bit elephanty in the room otherwise.
Yeah, there's lots of points there as we move from the traditional setup to where we're going. One thing just to throw into this is, like, we still have the power of the report on the internet. The kind of all the annexes and the like, and the more detailed analyses, which will be sitting for all to see on the internet, because everybody that we're dealing with will have access into the internet, to the websites that will hold the nuanced data and the depth data. Presumably that is a solution to part of this.
Yeah, I mean, just to come in, Danny, on a couple of the points.
Yeah, thanks.
Of course, yeah, audit providers can post on their websites any analysis that they like, of course. The annual report's not going. It's just important to emphasise that. What we're saying is it should be a State of the Nation report, 5 to 10 pages, that really informs the system. What are the system issues and what are the system recommendations? What we're not looking for is for lots of local recommendations that really aren't going to have the context that you need to do that. So and then the other issue around interpreting the data, completely agree, Jane. Of course, that can happen via the online near real-time feedback. So the results portal should have the information about how to interpret the results. I don't think you need the annual report for that.
Thanks, Ian. There's a Rebecca, do you want to come in?
Yeah, I just wanted to come in because in our project we did look at the process of data collection for NCAs. You know, so I really support this idea of going to real time. You know, people didn't make use of the annual reports because they felt that they were too out of date to be useful for quality improvement. But I also just think that the idea of moving to real time is challenging. So partly the issues that Jane was saying about in terms of automated data extraction, it depends on the systems that they have, but also there is all this work that we found that goes into checking the quality of the data before it's uploaded. And if you can't do automated extraction, it depends on how quickly the sites can upload the data. And certainly, again, that was something where we found variation between sites depending on the resources that they had in terms of audit support staff. The other thing to say is we spoke to people where, yes, theoretically they had access to the data on the NCA's website, but they didn't use it. So I think as more NCAs introduce online access to data, it's really important to monitor to what extent that data is actually being accessed.
Yeah, thanks. That's a really interesting point. Yeah, we always make these assumptions which aren't correct. Any other points on any of these various interesting presentations? Sam, is there somebody that Sam? No. Okay, so I think we've probably reached the natural break here. We thought we'd have 5 minutes just to give ourselves a little breather before we come back. And but I mean virtually, incidentally, not switching anything off. We've got four national audit groups who are going to present their experiences with their national audits. So we get a feel for the real world as well, what it's like at that end. So if everybody's fine, so it's 13:27. So say, well, 3 minutes is too short. So say 25 to 2, we reconvene. Okay, so that's about 7 minutes. So keep everything switched on, please. Don't log off. And 7 minutes, and then we're back again, 25 to. Thanks, everybody. Thanks, everybody. So this second part now is going to be listening to four colleagues presenting from their national audits. And again, this is the theme. So how do we stimulate improvement for patients? Improved outcomes for patients. That's what this is all about. Are we doing the right thing? Can we learn from each other on how we actually do this better? So Sam, are you there from the National Vascular Registry?
Yep.
So the first presentation is Sam talking about the Vascular Registry. Are you ready to go, Sam?
I should be, and you should hopefully be seeing a screen come up. Can you see that?
Yes, it's starting. It's up now, yeah. Thanks, Sam.
Thanks very much for giving me the opportunity to speak today. I'll start by doing a bit of background about the National Vascular Registry for those who don't know much about it. It's a procedure-based surgical audit that's at the Royal College of Surgeons of England, where I work, and it focuses on patients undergoing vascular, surgical and interventional radiology procedures. There are 3 main disease areas and 5 main procedures. You've got the carotid arteries in the neck, you've got the aorta in the abdomen, and you've got the lower limb arteries. And actually the aorta is split out into sort of 3 procedures as well. So I was interested in some of the discussions earlier about the number of metrics you should be publishing, which is a bit difficult when you've got 7 different procedures. Like all of the National Clinical Audits, as Ian would have mentioned earlier, we have a QI plan, and this slide is, apologies, is a little bit busy, but it's basically saying that most of our QI objectives are around reducing rates of complication and mortality for all procedures, increasing the proportion of patients for example, carotid surgery that get their procedure within 14 days of their initial symptom. And the one that I'm going to focus on mainly today is to do with the time from admission and referral to lower limb revascularization, because this is something that's fairly new within the last few years, and this has come about because of a document the Vascular Society, who are the professional society involved with vascular surgery, published a quality improvement framework back in 2019 as in response to the GIRFT report for vascular surgery, and they set some quite challenging targets, so that if a patient is an admitted patient, they should have their procedure within 5 days. If they're a non-admitted patient, slightly more stable, it should be 14 days. So what we did is we set up, in response to this, a quality improvement program, and we were lucky enough to be able to get external funding for this, because it wasn't covered as part of our NVR project budget. And we used the Vascular Society of Great Britain and Ireland, the Circulation Foundation, which is their charitable arm, and the Royal College of Surgeons of England, to basically fund a QI fellow. And we now have a second QI fellow who's also joined us. And what we decided to do was build on some quality improvement work that the Royal College of Surgeons had already done in gallbladder replacement, to involve 13 early adopting units, so it was how many could originally sign up for it. And the aim was for them to work together, identify common problems along the pathway, and share methods for improvement. And how we're doing this is we're using the QI methodology as mentioned above. We're using prospective data collection within the actual MVR, because we have access to our own data that we can export in real time. And we are in the process of setting up a bespoke mini database using the free data capture system called RedCap to capture a few more specific data items that aren't in the National Vascular Registry data, that will really pin down where these delays occur. And we decided to do this so we didn't want to introduce data items to everyone. If they are suitable for everyone, then we may put them in the NVR later on. And lessons learned from these early adopting centres will be shared with all NHS trusts once this piece of work is complete. And as we're going along, we are sharing some of our findings with everyone so that they're all aware of what we're doing. This is based on some metrics we published in the 2020 annual report, and it's basically looking at the proportion of patients receiving their procedure within 5 days for both the open surgical lower limb procedure and the endovascular one, and then the actual median number of days between it. And this is in the actual annual report as a static document, static image, but then within our more interactive appendices spreadsheet, you can actually go into it and choose your individual trusts. I've just picked, it's the one that appears at the top of the alphabet. You can pick any of them and it will highlight your trust in a different color and show where you are compared to the national target and then compared to every other trust in the country. And the final slide I was asked to talk about was where some of the lessons we've learned over the last few years of running the MVR. And I think having improvement goals that relate to existing recommendations that come from quite high places like NICE or consensus statements from professional service societies or GIRFT really will have the weight, and they will be supported by clinicians, and we've made sure that all the data, all the metrics we're publishing can be measured by data that's already collected within your National Clinical Audit. So far, we have reported these metrics in annual reports and the trust level appendices, and we also, anyone that puts data into the MVR can get data out either through online real-time reporting tables and graphs, or they can extract the data themselves into a CSV or an Excel file and do any analysis themselves, and we've provided guides for them to be able to do that. We have tended to disseminate the results at annual scientific meetings. We've actually got 2 coming up within the next 4 weeks, which is exciting because it's the first time I've seen some of these surgeons for a couple of years. We've had QI workshops with our early adopting centres for the PAD-QIP, and a lot of the work that we've done has been done in collaboration with the commissioners. A lot of the reconfiguration of vascular services that's been done over the last 5 to 10 years has taken into account data that we've published within the MVR. And thanks very much for listening. And I'd like to acknowledge the rest of the MBR team. It's not just me, and the PADQUIP early adopting centres as well, because they've really put a lot of effort into putting data in sort of real time, because this is the practice we've got. If this is going to be the way we're going to have to publish data in the future, the lessons we learn from these 13 trusts will really help us roll it out to other hospitals around the country. Thanks very much.
Thanks very much, Sam. That was very concise. Thanks for that. This is open for a discussion from colleagues. Anybody wants to fire away with a question to Sam about this registry and the findings? Any first questions? So I can ask you a question now, because this is a lot of very interesting stuff here. You give your principles at the end, linking these with national guidance, so to speak, GIRF, NICE, and then the second line was supported by clinicians. I'm assuming that's a given, but that maybe is one of these wide statements made by people like me, where it's actually maybe not true. Are the Vascular Society homogeneous in their happiness with this kind of approach to improvement, or do you get pockets of colleagues very happy to join in, and then others much more recalcitrant?
It can be difficult for some of them. Obviously, where a recommendation is evidence-based, such as a NICE guideline or a national target, there is less friction to it. Some of the lower limb ones have been set purposely quite ambitious, but I think they wanted to try and say that actually some of these vascular disease patients should probably be seen as urgently as some of the cancer patients, for example, that get a lot of the national targets coming from the NHS, because these patients are very important, and the longer you leave them, the more chances they've got of losing their leg, basically. And I think within vascular disease especially, there's been a lot of prioritization in the aneurysms, for example, but I think some of the last 18 months has shown that you can defer some of these patients, within a 5.5 centimeter aneurysm for a bit longer, whereas if you defer a critically ischemic leg for a month, then they're going to lose their leg.
Thanks, Sam. There's a question. James, do you want to come in and question?
Yeah, it was really just to build on what Sam said. I think getting clinician consensus around quality improvements easy if there's nice guidance that you can also evidence from the audit. But a lot of what we do clinically is evidence informed rather than evidence based, and that's where you tend to get the greatest discussion. And actually, there's Donald Rumsfeld's known knowns and known unknowns. And, so for instance, we demonstrated in our audit that if you were seen by a member of the respiratory specialist team within 24 hours of admission, your outcomes were better, your length of stay was shorter, you were considerably more likely to get evidence-based interventions. Now, that's not in any guidance, but it's generally accepted because we can demonstrate from people's own data why we're suggesting it as a national target.
Sure. It's in many of the audits as well, seeing the right person, the right time first. Thanks for that. Julie, did you want to ask a question to Sam?
Yes, hi Sam. Thanks for the presentation. Very interesting. Is the action and the audit, is it matured enough to be able to see whether or not those interventions and the way you've approached your QI has had an improvement in the data and in improving care?
For the lower limb patients, not yet, because it's still quite new. For aneurysms and carotids, we do have evidence that it is showing something, because they've been collected and published on for 5 to 10 years, especially the carotids. And a lot of the, as I said, the reconfigurations, they've looked at these pathways as part of the reconfigurations of vascular services, because a lot of those hospitals with large delays, they've been able to try and unpick them. And they certainly, when services stop doing surgery, there can also be issues where if you merge 3 hospitals into one, you've got 3 times the amount of patients coming through sometimes. And by publishing where the delays occur in the pathway, it's led people to unpick them, and they've been able to get things like extra theatre capacity, maybe extra consultants potentially, or extra imaging modalities to enable the patients to be seen quicker.
Excellent, great. Yeah, because I think as we started off this presentation, well, the whole thing today from Danny, it's not about collecting data, it's about seeing changes, and I think that's the crux of it, isn't it? Actually seeing the changes and measuring them. Great, exactly. Thank you.
Exactly. And any other questions for Sam? No. Could I ask you one last question, Sam? You showed one of your slides, and correct me if I'm wrong, maybe the interactive kind of bar chart that might be on the internet, where you could go and put your slider over a different hospital and see different results. Is that right? Is that what that is?
It is, yes. It's something that we've created within our department, and I'm learning each year on how to make things look nice in Excel, because I think the idea, I wanted to do something in Excel that didn't contain lots of macros, because it's got to be, hospitals have got to be able to use it quite easily, and you don't want to have to run certain programs that won't run in hospitals that block it. But yes, it's effectively pretty much all of the graphs and the plots we publish on our annual report as a static image. I try and recreate them so that you can select your individual trust, and your trust will be in a different color, so you can easily see where it is, rather than having to read your results off a table and then compare it to, say, a funnel plot or a graph and read it off.
And is that popular? Does that get many hits? You know, because we were hearing earlier on in the session that maybe people weren't going on the internet. You know, we all thought, oh, everybody on the internet, but maybe they aren't. Are you getting many hits on that?
I'm not entirely sure. The people that I know want to use it are happy with it, but that might only be the 5 or 10 people that tell me, rather than the 500 that I'd rather use it.
Yes. As ever. Okay, thanks for that, Sam. Any last questions to Sam before we move on? No, that's fine. Thanks for that, Sam. So we're moving on to the next presentation from very important National Asthma and COPD Audit. Colleagues are going to be presenting for their work. James, you're presenting?
Yes, so I'm presenting. Hopefully you can see my slides.
Yes.
Yeah, thank you. So I'm presenting on behalf of my whole team here. The NCAPOP audit's fairly large in extent. It covers COPD, adult asthma, pediatric asthma, delivery of respiratory care in primary care, pulmonary rehabilitation, and linkage of our data with nationally available NHS 30 and 90-day outcome data. Our aim, obviously, is to improve standards of care and outcomes for patients. So I've been asked to just cover a very specific part of what we do, which is our quality improvement training offer. That is supported by all the other work we do. So as a result of data from the audit and lobbying by the team, we had sequence and best practice tariffs that were informing care in delivery of both COPD and asthma care. We are the main vehicle available nationally for assessing progress against the NHS long-term plan, and we're also looking at how we can provide real-time comparative data to regional respiratory networks who are responsible for delivering care across the country. But research published by John Hurst and Jane Ude and other colleagues has shown that to achieve change in outcomes, you need quality improvement, financial incentives, and continuous data collection, with that data reported using run charts that are useful for teams who wish to improve quality. But what we found previously is that teams struggled to know how to use data and actually how to do the difficult work of changing the way in which they deliver care. So the aim of our quality improvement component of NACAP is to create a sustainable framework even after the audit finishes, and resource which stakeholders and clinicians can use to improve respiratory care. In delivering that, we have partnered with the Royal College of Physicians Education Department, who have a lot of experience in delivering training, particularly in the current environment, using sort of virtual techniques. And we've decided to run a large-scale pilot using a number of regional QI mentors who are going to support respiratory teams through their development plans. And that's an entirely online program with two components. The first is a sort of an offline training component with one of our modules available to train QI coaches, and that gives them skills that they may not have got during their everyday work of how to facilitate online groups, develop ideas, physically use the platform and teach people how to teach. And then there's a sort of a more conventional module, which is the one on the right-hand side, which are bite-sized modules ranging in length from 7 to 20 minutes that teach people how to go about doing a QI project. And it's not just the NHS model of improvement around small tests of change, etc., but it's also a little bit about the psychology of improvement. How do you build a team? How do you motivate a team? How do you identify barriers and overcome them? And the aim is that these teams will come together in regional groups supported by their local regional mentor to learn from each other how to deliver on their QI objectives. So after they complete the online learning modules, they will have developed a basic aim statement and a basic driver diagram that they will then refine on online webinars led by the NACAP team, RCP Education and the QI coaches. So where we've got to now is each of the regional respiratory networks in the UK have identified a facilitator who we've now trained. We've got 150 learners in 50 teams from all areas of the UK, all areas of England and Wales rather, who this month are going through their sort of kick-off workshops. They'll have finished the online modules and they're now being supported to develop their ideas. And this will be followed up with a series of regular online webinars with gradually the NACAP team pulling back, but the QI coaches using the RCP platform to continue to deliver that mentorship, which we're expecting to last for 6 to 12 months. This is a new approach for us to delivering QI, but it was something that we found that we needed after a critical analysis of our QI approach from the first 3 years of the programme, where we found that people appreciated the gain in knowledge that they got from our initial offer, but what they wanted was ongoing support. So we're going to assess our impact by looking at sort of process measures such as how many people have completed the modules and completed the sort of whole 12-month course. But we're going to have the opportunity of comparing improvements in audit outcome data for participating teams versus non-participating teams. And we've got the real-time run charts, and we'll be able to look at changes and trends of improvement for teams. We're also working closely with the teams who are participating to check on the fact that they are showing an improvement in their knowledge and that they are grasping QI skills. And we are looking now to see how we can include patients as in part of the evaluation, as well as patients have really informed every other aspect of NACAP as it's been developed. So at that point, I'd be happy to stop and take any questions.
Microphone. Yeah, thanks. Thanks. I haven't got the knack of turning a microphone off. Yvonne, far away there. Thanks.
Hi, James. Thanks. Really interesting. Excited to hear of all that work. I was wondering whether respiratory trainees in any form will be inputting in this programme, because they always seem to be an untapped resource when it comes to QI, and they are the folk of the future for leading QI, I hope. So
in fact, one of our regional QI facilitators identified by the regional respiratory team is actually a respiratory trainee. We've had some respiratory trainees who are particularly interested in this, who are members of the teams that are delivering QI. And I know myself from delivering these sorts of programs via the British Thoracic Society that very rapidly teams understand that trainees are a key component of delivering the QI, because they have a requirement as part of their training to participate in both management activities and quality improvement activities. So they're involved at every level.
Yeah, they're a real untapped resource, as you say. Gerald, did you want to come in on that?
I think you're on mute, Cheryl. The catchphrase for 2020-21.
I know, yeah. Do you want to try again, Jill? Yeah, you've done my trick. You've muted again in your attempt to unmute. Try again. Yes, you're on. That's
I
good.
think maybe your microphone isn't plugged in, Cheryl, because I think you're off mute, but we still can't hear you, I'm afraid.
Is that better?
Yes.
There you go.
Yes.
Now? Okay, sorry about that. Okay, I can't remember my question now. No, with regard to the online workshops that you've developed, are they generic or specific for your own National Clinical Audits programme?
So when we set off on this, Jane, with her sort of lead role at RCP, asked that we develop something that could be applicable to any audit, and that's the sort of plan we followed. So the vast majority of what we've produced is generic, with very clearly defined areas that is disease specific, and literally, if you wanted to use it for another audit, for the most part, there would be a few example slides you'd need to change and then just switch the PowerPoint background.
Yeah, that's it. Perfect.
Okay, that's very useful. Thank you.
Yes, very excellent. Ian, did you want to come in?
Yeah, I agree with what's been said, James. Fantastic piece of work. I just wonder if you could elaborate a bit on how you're funding this, because one of the things I heard during my fellowship from many of the audit providers was that they don't have sufficient funding to do any quality improvement work with organisations. So can you share any insights on that?
So I think my colleague Lara, who manages the projects online, so I think there has been a degree of financial alchemy. We're obviously spending a lot less on travel than we were before and on face-to-face meetings. And in fact, we invited a pharmaceutical company along before COVID to observe what we were doing. And they were so impressed, they gave us an unrestricted educational grant with no strings attached to allow us to expand some of the work we did. So it's a mixture of using our budget very prudently and bringing in an extra bit of money to do work that we think is important.
And we also are using some of our underspend from HQIP.
Excellent.
And I should say that one of the things that none of the QI facilitators are taking any payment at all, so it's being done because people think it's a valuable thing to do.
It's impressive. Well done. Yeah.
Thanks, Kim. Is Kim coming in next?
Thanks for that, and it's really great to hear about the work at ASMA, and you've been the first person today that's talked about patient and public involvement. So I was just wondering, when you said you're going to talk to, I know you do some great PPI in the ASMA. So I was just wondering, when you say you're going to share some of this work now with the patient groups that are involved in the programme, how do you think that they can support QI?
Yeah, so I don't have a clear answer for that. And actually what we're doing is we're exploring with patients how we use their time to best advantage. So where patients have been involved in the past is, Ian will remember from a long time ago that patients were involved in the drawing up of the initial data set that was collected as part of the audit. We produce a different paper, we produce a different annual report for patients that's in a format that's accessible to people with a range of disabilities and reading levels. We work with a number of third sector organisations to disseminate results. And every year, one of our national improvement objectives is one that patients have defined rather than professionals. And what I've not managed to yet separate out is the technical aspects of quality improvement, i.e. what do you do and how do you do it in a hospital, from how do you get patients involved. And my feeling is probably the best way is going to be to have groups working on QI initiatives in hospital having a local patient who participates. So I guess the next stage of this audit would be that we provide some bespoke training for patients who want to participate in QI. We haven't got there yet, but those are the sort of thought processes that I'm on.
That's excellent. Thanks, super for that. Thanks, Jane. Sorry, Kim. No, Kim, Jane, you're next. Sorry, excuse me, I'm getting caught up here. Jane, fire away.
Yeah, so thank you for your generous comments, James, and this is all very exciting, and I know the team have been working really hard. I'd like to reassure sponsors that we are well within our budget. We're not spending it. But we're also undertaking a similarly slightly different approach in one of our other national audits. And we're looking at a different way of involving patients in that project as well. So I think we're going to start to have some powerful data soon and experience about how we can and cannot meaningfully involve patients within QI. I think our two larger audits certainly have a strong history, strong reputation for quite good patient involvement and guidance. And I think it's just, as James has pointed out, and as we're looking at in one of our other projects, we'll be looking at understanding how we best involve patients and the really precious resource and the kind of work that they put in, but making sure again that we're aiming at the right people to deliver the right thing, which is all important in NHS work, isn't it?
Of course, thanks.
I agree. I mean, I think in the NHS there's a danger of tokenism in involving patients, and people are giving a lot of their time, usually their own time, and I feel that ethically we need to make sure that we use that time reflecting how precious it is, really.
Sure, I'm sure we'd all agree with that, of course, thanks. Maybe we should move on to the third audit we're going to be listening to this afternoon. Colleagues from the National Early Inflammatory Arthritis Audit. Are you up and running, ready to give us a presentation this afternoon?
I hope so.
Oh, good, thanks.
So, Carol, what we're going to do, because we've noticed your connection is quite poor, we've actually displayed your slides. They're available now, so you don't need to share your screen.
Okay.
Yeah, in fact, yeah. Is it okay if you stop sharing your screen and then Ollie will share your screen and then we'll ask you to minimize.
Okay, does that work?
Okay, let's just see. Yeah, great. So you've stopped sharing, which is fab. And then Carol, can we ask you to stop your video? Don't leave the meeting, but just stop your video.
Okay.
Perfect. So can you hear us, Carol?
I can hear you. If you can hear me, that's a good way to start.
Yeah, we can definitely hear a lot better now. So just let me know when you want the next slide to go. Okay.
Okay, thanks. So my name's Carol. I'm based in South Wales. I'm part of the National Early Inflammatory Arthritis Audit, and I'm representing the BSR. So thank you for sharing our work. So this is all about patient outcomes, isn't it? And certainly for a person presenting with inflammatory arthritis, the one thing that will make a difference to that patient is a prompt diagnosis. So whether or not they go on to develop a disability or whether they go into remission is determined by how quickly that diagnosis is made. And that is key and central to this audit. And all the work we're doing in this is looking at that main outcome. Can we prevent somebody from becoming disabled from their arthritis? Generates unit level data in England and Wales for all patients over 16 years of age with a possible inflammatory arthritis. And the data is presented against 7 quality standards as set out by NICE with national benchmarking. Next slide, please. So our first annual report was a lengthy document and it was published in 2019. And of those 7 quality standards, it was clear that the 3 first that we had were the ones that predicted patient outcome and disease outcome. So the first 3 key standards were the ones we needed to focus on. And those standards were, how long did it take a general practitioner to refer in a person with suspected inflammatory arthritis, our goal being 3 days. Second standard was, how long was it before that patient who was referred in was seen in secondary care, and our goal there was 3 weeks. And how long before that person who had a confirmed inflammatory arthritis, how long was it before they started on their disease-modifying therapy, which would go on to induce remission? So those were the 3 key quality standards we needed to focus on. And our quality improvement plan, therefore, was based on those 3 metrics. Next slide, please. And it was useful that we could base that decision on the results from our first annual report, that it showed very clearly the best predictors. So how did we go about it? Well, like all national audits, it was a huge approach going down from the top, from UK-wide, nationally led by the BSR, and linking it to those drivers that you have in England, GIRFT and best practice tariff, and then linking it into gold from the Welsh Government as well. Also linking in with other bodies like the Royal College of GPs, because of course we were asking GPs to refer patients in earlier. So this wasn't just a secondary care-based audit. Key to our approach as well was the appointment of 5 local champions by the BSR within all the regions and countries taking part in the audit to disseminate this information at a local level, to feedback not just on the QI plan, but to look as well at highly performing units and feedback what had worked well in those areas. There were plenty of QI tools that were downloadable from the BSR and the audit website, looking at best practice examples, looking at driver diagrams as how to instigate change. There were quarterly reports issued, again highlighting the high and the low performing units. Next slide, please. And then our next annual report, published in 2020, showed our performance, our QI performance against these 3 metrics that we'd chosen to focus on. And we had set ourselves targets as suggested by an earlier speaker. So for quality statement 1, how quickly do GPs refer in? 41% was the achievement with our first year report. This went up to 47%, which was a 6% improvement. With our second quality standard, how quickly were we seeing these patients in secondary care? This went up from 38% to 48%. We had set ourselves a target of 5%. So again, we exceeded our target there. And for the third quality statement, possibly the most important, how quickly were patients started on disease-modifying treatment? This went up from 54% to 64% within the 6-week target. And our target for improvement had been 10% there. When we looked back at our unit data that each local unit had provided, we were able to see what sorts of changes had happened to enable these achievements to occur. So we were looking at things like new posts for nurses, AHPs and consultants. We were looking at dedicated early inflammatory arthritis clinics being set up. We were looking at quite marked changes in referral triaging. So going from paper-based triage to electronic triage, and looking as well, not at weekly triage, which was happening in many places, but looking at daily triage of early suspected inflammatory arthritis patients. And we were also looking, and we could see that there had been GP education focus groups set up to highlight the aims of our audit and in order to get better patient outcomes. And our main outcome was remission of disease at 1 year. Now, our first audit, our first annual audit, we didn't have data at 1 year because it hadn't been running long enough, but we knew there was 37% of our patients at 3 months would be in remission. For our second annual report at 1 year, we could see that number had gone up to 52%. So 52% of our patients referred in achieving remission. That's still not good enough. There's more work to be done, but it does show a definite improvement and a measurable improvement. Next slide, please. We were asked to comment then on what our learning was from this and what the top tips were. And again, this mirrors what a lot of other people have said today. It's really important to have measurable patient outcomes. Our measure was remission. We are now able to measure that and assess performance against this. Local ownership of data is really important. And like other audits, we are able to see our data in real time and download it in real time to see what effect our quality improvement plans have in real time. The other important thing that maybe hasn't been mentioned yet, when we publish our data, we publish it in a contextualized way. So when we look at poorly performing units, we can look at those results in the light of what the local workforce is like there, because there are huge areas within rheumatology where the workforce is really low, and that then explains the poor audit data. And I think that's really important for units. When they see their own data, they can match it to their own demographic in terms of comorbidity and in terms of workforce. we've linked everything, of course, to local drivers like NICE as well. And I think the final thing I'd like to say is that the emphasis from the BSR at every level here has been support rather than scrutiny. A lot of the work is focused on looking at the low performing units, and what those units need is support, not scrutiny. And because these figures are all in the public domain, I think there has been a lot of fear before reports are being published. And so being able to see your own data on a monthly basis and download it, you can predict maybe if things are not going well, and then you can try and intervene and help and support those units that need help by looking at other units that have made real positive moves, and you can look at and try and analyze what have they done to make a difference, and we can then share that experience. And the BSR has been very good at doing that. Thank you.
That's super. Thanks. That was very, very clear. Thank you. That's really good. This is open for any questions. So, anybody want to ask any first questions? I'm going to pick up that very last point, that the very last point, support versus scrutiny. We've got an awful lot of experience of that the other way around on the surgical audits, scrutiny surpassing support really, and really been very difficult for many audits to work their way through. So actually, it's very interesting hearing that when you set this up for really with a support kind of ethos, that actually maybe a better, much better way to go as we develop further audits. There's a question here. Parangata, is that it? Are you there?
Yes, hello.
Hi.
My name is Penny. I work as part of the National Vascular Registry team. I wanted to ask, how did you engage with the general practitioners in the community? Because we have similar timelines in our audit that we're looking at, and some of the participating units and clinicians working in tertiary centers, they have difficulty in that part of the referral process, and spreading this education in primary care about the patients and the referral.
I think this was done in many ways. One way that it was done centrally is that the BSR have produced learning tools and online courses for GPs that they can, and we can track, of course, how many practices are logging in and using educational resources. The other thing was that because one of our targets is how GPs refer in, and we're asking GPs to refer in within 3 days, and that's been a big shift. The previous practice in that GPs are being asked to refer patients in before they get the results of their blood tests back. So historically, they might be waiting for positive serology or high inflammatory markers. We're really reversing that message and saying you have a high index of suspicion of inflammatory arthritis, then you refer in. And that's been a very clear message from rheumatology units, not just from medics, but from nurses who interact a lot with practice in terms of monitoring of these chronic illnesses. And so the message has been passed down on many, many levels, but backed up by online courses provided by the BSR, and also linking in with the Royal College of General Practitioners as well, of course.
Thank you.
Super. Just on that point, are there any links with QOF, general practice QOF, between the audit?
No, we've been really underrepresented in QOF. The annual
You've broken up, Cheryl. Maybe if you turned your camera off again, that seemed to work pretty well last time. No, we've lost it.
Okay, can you hear me now?
Yes, that's better, definitely.
Okay, I'm trying very hard to turn my camera off. It doesn't want to.
Yes.
We've been underrepresented in rheumatology and QOF. That's something we jump up and down about a lot. So we haven't been able to. I think it was linked in for the annual review for rheumatoid arthritis, and that was one of the metrics we had as well. But time to referral isn't mentioned in QOF.
Okay, fine. Any other questions for Cheryl on this very interesting audit? I'm not sure, but basically what you've actually done is shown an improvement, which is what we set out at the very beginning of this meeting to do, is like how can we make sure that the audit programs are actually showing improvements, and it's excellent that you've actually seen a really good example of that. If there are no more questions, Gerald, we maybe move on. Right, so thanks for that, Gerald. The last presentation is from colleagues from psychiatry, the National Clinical Audit of Psychosis. Colleagues there ready to talk? Is that Amy?
Yes, sorry, just trouble getting myself off mute there. Hopefully you can see my screen now.
Yes, we can indeed, thanks.
Perfect, thanks everyone. Yeah, so I'm from the National Clinical Audit of Psychosis based at the Royal College of Psychiatrists. So NCAP has been running since 2017, the primary aim of improving care to people with psychosis in mental health trusts in England and health boards in Wales. So as an audit, like the rest of you, we monitor performances of services on an annual basis, and we benchmark services against each other and against national averages. However, it's obviously more difficult for us to evidence what difference these improvements in performance actually mean to people with psychosis receiving the care. So with that in mind, our quality improvement aim is to try and evidence the impact that improvements in quality of care delivered by early intervention psychosis services made to people receiving the care. So how do we evidence this? So one of our audit standards looks at outcome measurement data for service users, and we ask that these should be recorded at least twice in the service user case notes. So this enables us to see if services are monitoring a person's problems, treatments, satisfaction or recovery, and whether the treatment goals are being received. So, and in the current round of audit for this year, we've gone one step further and actually looking at collecting the outcome scores from one of the outcome measures itself at both time points, enabling us to capture the changes in scores, allowing us to see improvements to the individuals actually receiving the care. There's also an additional motivation for teams to record their outcome measurements in the audit, as performance in England is scored in our reports, and this score is provided to NHS England to assess progression towards objectives in the early intervention psychosis access and waiting time standard. So there's a target for trusts to achieve a paired outcome measures for at least 50% of their service users. So the scores provided by the NCAP audit actually feed into that as well. And at the end of each round of audit, we facilitate QI webinars. And because of the pandemic, the last few years, these have been held online, but these are designed for audit leads and early intervention psychosis staff, and led by our QI experts and our audit clinical advisors. And the webinars over the last few years have focused on the outcome measurement data from the audit and how this can be used to review and improve the quality of care provided to people receiving their care. So this year, the sort of focus of the audit, we had several services themselves presenting about the experiences of recording and using outcome measures, barriers and facilitators in collecting and using this data, and sharing examples of good practice and learning to other colleagues. Oops, skipped too soon. These service user presentations are then followed by a panel discussion about ways to improve service users actually taking up interventions as well, and strategies to reduce refusal rates. So there's also a discussion again there about how this can actually help the people receiving these services. And during these discussions, we have our service user advisor, Vinu, present, and she feeds into those, ensuring that the service user perspective is always kept at the forefront of those discussions. So that's a bit about in terms of what we do in terms of our QI approach. In terms of impact, since the audit started, in 2017, we can see that there's been considerable improvements in the recording of routine outcome data. So when we look at the national data, we can see in 2017, it was just 9% of case notes that had 2 or more outcome measurements recorded at least twice. And in 2020, this rose to 55%, which is an increase of 46%. And just finally, just to kind of reflect on some things that we've learned, particularly from our QI workshops. So we found that these often work better when they're a bit more informal and allow for discursive conversation between the audience and the services presenting, or the other panel members, to enable them to share what they did and how, and sort of share ideas and best practice. Something we found, particularly this year, that's important is the timing of these workshops. So we need to ensure that we allow enough time for teams to see their results and go through this data before scheduling these sessions, to allow them to reflect on the data and implement any changes for that. In terms of the QI workshops as well, this is obviously a space for teams to reflect on the audit data as a group, but we obviously only do this annually. So in our team, we're starting to think about how we can share resources and good practice examples outside of these formal events. And another important thing in terms of everything we do is about collecting regular feedback. So again, how we can get that information about how we're trying to collect that data ourselves, from data collection, presentation of data, and the actual QI events to continually improve. So that is the end of my presentation. Thank you for listening. If anyone's got any questions.
Thanks for that, Amy. And any questions for Amy in relation to the psychosis audit? Any points anybody wants to bring up? The workshops that we've heard about workshops several times, quality improvement workshops. How interactive were those with the patients, if you know what I mean? And were they? You mentioned about the more discursive discussions. That would give the impression that they were fairly interactive.
So it's not, patients don't attend the workshops themselves. So we have our service user advisor who sort of represents the views of those patients. But it's staff in the services that we're auditing that would attend those, that would lead those discussions. But in terms of our involvement with patients, in terms of our reporting, when we get the results for our audit, we work with Rethink Mental Illness, and we have a discussion about the results, and they will provide insight into why that's important for them. And that also then feeds into our report. So it is included in our reports in terms of that involvement as well, but not directly in the QI workshops themselves.
Right, thanks. That's super. And any other questions for Amy? No. So you have reported improvement in reporting, reporting through the notes, but do you actually think that there's actually improvement in for a person first presentation with psychosis? Is that other improvements in that?
Well, that's what we're trying to do this year with collecting the actual scores themselves. Right. So we're going to collect the scores at 2 time points. So the first assessment done and then the second one. So in this round of audit, we'll be able to see that difference in terms of how that person is doing. Okay. So we'll be able to report on that next year, hopefully.
Okay, that's super. Thanks for that, Amy. And any other questions anybody wants to throw into Amy to the psychosis audit or any other points? No. Okay, you've obviously stunned everybody, Amy. Thanks for that. So we've had 4 very interesting presentations here, all to do with this theme, and this morning, earlier on today as well, this theme of how do we ensure that the National Clinical Audit Programme in all of its different guises leads to improvement of outcomes for patients? And we have had examples of this, but obviously that has to be, like when the audit programme started off, there was a lot of thought about assurance coming from the programme, that colleagues want assurance of this service, that service, the other service, what we're doing, what they're setting out to do. In some respects, many of our services are assured, and now we're really coming in on the, okay, we've got an assured service, but is it an improving service? And that is what we are being tasked by NHS England to look at much more actively. We have always looked at it, but it's now the main focus. And this is a start off, as I see it, where we actually all focus on, have we got the right metrics? Are the metrics really set up to look for improvement and outcomes for patients in all of its guises? And, you know, if not, let's make sure we are. So anybody has any other thoughts they want to bring in on that? Is there anything we're missing in the National Clinical Audit Programme in the way we commission and set it up that we could do differently to ensure that we have a better and more aggressive focus on the outcomes for patients? Anybody want to throw in anything on that one? You can see the themes that we're coming in on. Reducing metrics, so we've got focus metrics, trying to get much closer to real-time data as much as we can, getting that data cleaned and out as quickly as we can, and going along with that is the annual report being focused. So Bonnie, I think you were first in with your hand.
There we go. Put myself on mute. Yeah, I was just going to say a bit, something that we found really helpful, and now we're kind of up to full speed again, is the wording around trusts and these being mandatory audits for trusts to support teams to be able to collect the data. I think that's a really, that's often where the stumbling block is actually having the time and commitment to be able to enter that data, and having the support from trusts to do so.
And so, sorry, just so I get that right, so that's a HQIP role working with NHS E&I that actually trusts understand
about
that these aren't arbitrary things. Yeah, okay, I've got that, yeah.
Thank you.
Thanks. And I think, Jane, are you next?
So just briefly, I think I just need to, so I understand the challenges coming at you, but I think we need to reflect on the fact that there has to be sustainable improvement, and a quick win needs to be sustained. And as our first presentation really helpfully explained, that it's sustained and ongoing improvement that is important for patients. And there's something about striking the balance, isn't there, between easily accessible and interpretable data that people can use in their everyday clinical work to improve patient experience. But that needs to be sustained. And I think it's really important that despite the challenges that we're coming over, it's really important to keep that narrative that you can improve things possibly for a short time, but you need the programs such as we're involved with to determine and develop and learn from what we've been doing to deliver sustained and ongoing improvement. It's not always a quick fix, as everybody on this call knows, but audit is really fundamental and important, but it needs to be done in a sustained and ongoing manner. Otherwise, a lot of work and effort gets lost very quickly. We've all been through the perils of a quick PDSA. The enthusiasm goes and then everything slips back to how it was. One of the great important areas of these national audit programs is the data that shows the year-on-year improvement, as well as immediate data. You need to know how things are going in a trend, not only on a micromanagement layer, but on an ongoing. And it doesn't always happen overnight, but it does happen, and some of that is having that narrative as well. And some of the audits I'm involved with can show that over a period of 10 years, we've reduced mortality significantly, but that's been over a sustained 10-year period. I accept that's a difficult narrative to share at the moment, and it's really important that we improve how we get that data to clinicians in real time, but it's not throwing the baby out with the bathwater to a degree. And it's just keeping that narrative, I think, is really important, that there's sustained and ongoing improvement, not just immediate improvement.
Okay.
I'm really sorry, I'm going to have to go, but thank you.
Of course, thanks for that. And James, maybe last word for you, James.
Yeah, so I think my concern about accuracy of data and real-time data depends very much on what you're doing with the data. So we have run charts for all of our sort of quality improvement targets that update every 20 minutes. So if people put in data, they get their own data back analysed immediately, so they can use it for quality improvement. We're working towards monthly dashboards available at a regional level, and where we've had to be careful there is with the sort of small numbers things. So we suppress values where I think we've got less than 5 cases off the top of my head, and then where we need to do a lot of data cleaning is for the national reports, because we're doing different sorts of analyses there. So I think you can you can accommodate within our sort of total framework immediate data reporting, but have alongside it the need to treat data differently depending on the circumstances.
I totally agree with that. Yes, the real time versus the really heavily assured data for at the end of the year. I totally agree with that, and we that message has come out to us. I think I think we need to pull this to a conclusion. So thanks very much, everybody. This has been really helpful. We've been recording this and we're taking notes, so we'll be pulling this together. So and just to reinforce, this is the theme. The theme is to do with making a difference in terms of outcomes for patients through the national programme, and we've got lots and lots of help from yourselves, and hopefully we've helped spread that around a bit. We will bring this together, and I will bring the meeting to an end now, because I see people are starting to need to move on to other meetings. So thanks for all your time. Thanks for all the presenters. Excellent presentations, mostly keeping to time. In fact, any loss of time was mine. So thanks again, everybody, and we'll be in touch with when we've got this together fairly soon. Okay, thanks everybody, and we'll say goodbye.